So learning curve in smile is, I think, very, very important. Always being a doctor, I myself explain to the patient how exactly he has to behave on the table. So optimum application of the anesthetic drop is also very, very important. So always try just put a drop or two maximum so that epithelium will not be loosened up. Being a doctor, always I myself check all the parameters in the machine, very, very important, including the energy setting which has been mentioned by the Dr. Kala. Once everything done, then machine will start calibrating for that particular patient. Proper draping is very, very important. Make sure that the surgeon will have very comfortable space to operate. There should not be any eyelashes coming on the way. Adequate wash of the ocular surface and the cornices is very important. Make sure that conjunctiva will be dry and cornea will be semi-moist. So head positioning is so important. Sometimes patient with a long nose, you may have difficulties to talk. So always you should tilt towards the opposite side. Connecting and selecting the appropriate size cone, important. In Indian scenarios, we take a small size cone. Take for right eye, you take in the right hand and hold the cone or contact lens in the right hand. Go to the slot, you take it up, then you'll hear a click sound. Once it is click sound, already the machine has already started calibrating for that particular cone. So white to white less than 12 mm, always 80 to 90% application is sufficient. More than 12 mm, 100% application you have to do. So we started with the flex. I just wanted to tell all my friends how this smile has been evaluated. So we started with flex. So the treatment will be done by the machine, similar kind how it does with the smile. This is what I learned 14 years before. So it started with the flex. So it has done treatment in both anterior and posterior plane. You could able to see. Once the dissection of anterior plane, then you have to lift the flap only. See, now I have lifted the flap here. Now I go with the smaller end of the dissector. I try to dissect the bed to look for the lenticule. So once you look for the lenticule, then it's quite easy. Make sure that you are dissecting, then go with the micro forceps. Try to do something called reverse rexis. This is how we started like this with the flex. Then reposit the cap back, nice ironing, so that the procedure is quite similar to the LASIK. Then we thought how we can really convert this. I just wanted to show you the evaluation of smile. From flex, then we started thinking about, okay, let us do something called pseudo smile. This is what me and Dr. Rupal started. So treatment is similar, like you started with a posterior cut, then with the cap cut. So here the incision has been done by the machine, similar kind how it is with the flex. But here what I am doing, I am not opening the cap at all. So to train myself as a smile surgeon, I started with the flex. So first I identify the anterior layer, then followed by the posterior layer. So probably this is what when Dr. Professor Tithial started, he was there, I was there for that particular training. So go with the longer end of the dissector, try to dissect in the anterior or the superior plane. See, you could able to see while doing only some of the flap might have been already cut. The incision might have gone from 4 mm to 7 mm. But I wanted to make sure that how exactly we have to do the smile procedure. So dissect the anterior plane properly. Now go to the posterior plane, try to dissect. So the one very important point I want to tell, when you dissect in the posterior plane, you dissect both the side equally. Otherwise, the entire lenticle may come and fold to the one side. So you have to dissect in such a way that you dissect both right side and left side. That means nasally and temporally equally, so that the lenticle will not be folded. Once the dissection over, then you go with the micro forceps. You try to take out the lenticule and you can put it over the cornea to look for the integrity of the lenticule, whether it is proper or not, whether it is round or not. Once it is done, then I think how you do with the smile, the ironing of the cap has been done. Then we started the smile. So smile, as you all know that, it starts with the first the lenticule cut, then with the cap cut, then with the incision. Initially we should start with the 4 mm, then you can reduce up to 1 mm also. Now, identifying the right plane is very, very important. First, you identify the anterior plane, then you followed by the posterior plane, then you turn the dissector into the longer end, then try to go in the anterior plane, try to dissect something called a windshield wiper movement. So this movement I think really help. I think any of this CLES procedure you have to do this kind of movements only. Now you go to the posterior plane. As I said that when you are dissecting the posterior plane, don't dissect one side. Both nasally and temporal, it has to be dissected equally well so that lenticle will not be folded. You can even use a simple McPherson forceps to look for the integrity of the lenticle. I want to just share with some of the complication also can happen when we started with Visumax 500. The incident of suction loss was quite high. See here you could able to see already there are black spots are there. The very, very uncooperative patient, you could able to see there is a suction loss. So not to become panic, suction loss during the lenticle cut, you can convert into the femtolasic on the same step only. If the suction loss during the other step like side cut, cap cut or incision, then need not have to, you can reduce the optical diameter by 0.5, then go back to the incision, recentration after the suction, then clear the bubbles from the center of the cornea, wipe the undersurface of the contact lens, then immediately you redock it. It will do the treatment in the same plane. These are the some tricky situation. One of the retained lenticule I wanted to show you. Treatment has done perfectly by the machine except for few OBLs. First, the identifying the anterior layer is done perfectly well, then followed by the posterior well. See, now you see, this is one of my favorite student now. He is one of the leading refractive surgeon in Delhi. I don't want to name him. He started with the anterior plane perfectly. Then he went to the posterior plane took his eyes off. Then I told him, you take out the lenticule. He took out the lenticule, then he has put it over the cornea. There was only half lenticule was there. Then he was become panic, not to become panic at all, because Zeiss always give a fantastic microscope, or someone can even use the triamcinolone. Here I did not use the triamcinolone. I fine focused it. I knew where it is exactly the remaining lenticule is adhering. Go with the longer end. Try to dissect very smoothly. You should not become panic. Try to dissect it out completely out. Then go with the microforceps wherever it is adhering. Try to go towards the 6 o'clock, that is away from the incision. Then you can take it out, then put it over the cornea. Then I got the remaining lenticule which I kept in the conjunctival sac. I joined it. Now it has become perfect. So always you can come out with a good result. How to avoid thin lenticule have higher risk of tear during the dissection. Dissection has to be gentle, no forceful dissection. This is the key one factor. This is one more case I am showing you, lenticule and flap. Say treatment has done perfectly by the machine. Identification of the both anterior plane and the posterior flap also done by the doctor really well. Now the surgeon really gone with the longer end of the dissector. He started dissecting. So I could able to see when he is dissecting, it is very smooth. Now he is trying to look for the posterior plane. He is inability to see where exactly is the plane. So what went wrong? Multiple entries in the interface during the dissection, inability to identify the correct plane during the dissection. So how to manage it? So go with the shorter end of the dissector, try to scratch the cap. So when you start scratching the cap, suddenly this lenticle which is adhering to the cap, which is going to open. Once it is open, then you can either go with your microforceps, or you can introduce your longer end of the dissector within that gap so that you could be able to dissect it. How you dissecting the posterior plane? As simple as that, not to become panic, keep your head cool. Then wherever it is adhering, you can go with the microforceps, try to dissect it out. Then I think like how you doing the reverse rexis in cataract surgery, you can take it out and you can put it over the cornea. See, points to remember, always identify the anterior and posterior plane properly. Multiple entries has to be avoided. Anterior plane has to be dissected first, followed by the posterior plane. So this is one more case. One is biggest irritating for any of the surgeon is black spots during the surgery. See, you could able to see a lot of black spots are there. What are these black spots? These are the areas of untreated corneas. So normally everybody will have a difficult dissection. So how to manage? Always in this case also you should identify the plane correctly. Most importantly, be calm, be confident. So go to the plane first, anterior plane. You will have all tough spots, or you may find a little bit stiffness while dissecting, try to dissect it, then go with the micro forceps. You may have a little bit more difficulties, then try to dissect it while peeling also. Hold it wherever it's holding, slow peeling, like you should go to the 6 o'clock, go and try to take out the lenticule. Successful removal of the lenticule is always possible. So, uh, how to avoid? Keep the conjunctiva and fornices dry while cornea has to be moist during the treatment. Avoid excess of applanation of the cone while docking. In the small cone, as I said that only 80 to 90% sufficient. If the black spots are extensive, then I think you can go ahead with the PRK. Thank you. I thank Dr. Jairaman and the entire team of this course.